occlusal cants. So I mentioned that orthopedic stability, for simplicity's sake, I mentioned orthopedic stability of the TMJs of the occlusion, but there's also an orthopedic stability of the atlanto-occipital junction, okay? This area right here is crucial for the symmetry and the balance of the head, okay? And in fact, if you want to really think about it even more, the fossa here, the fossa, which is in the temporal bone, is connected through many of the skull bones, including the occiput. So the temporal bone is actually connected to the occiput. So if there is a subluxation at the level of your atlas and your occipital condyles, there's a rotation, that's going to change the position of your fossa. And that's going to change the position of your TMJs, and that's going to change the position of your occlusion. Okay? And the person that I would recommend, there are two people I would recommend to listen to if you're interested in this. There's Mariano Rocobado, who is a physical therapist from Chile, who talks about the orthopedic stability of the atlanto-occipital joint, the TMJs, and the occlusion. And the other person is Jay Levy. Jay Levy was here I think a few months ago in Vietnam. Some of you may have attended his lecture, okay? Anyway, so let me explain how this works and how a cervical spine problem can give you an occlusal cant. Okay, your cervical spine is made up of 7 cervical vertebrae, okay, 1 through 7, and then of course then you have the head on top, the occipital condyles. We call the occipital condyles C0, okay? Your entire cervical spine has multiple ways of motion. There's flexion, extension, lateral bending, rotation, okay? Rotation has multiple elements. The 2 segments of your spine that are mostly responsible for the rotation are the C1 and C2. So atlas and dental, and dens, okay? C1 and C2. That's one segment. The other part is the lower cervical spine from C3 to C7. Okay. And then there's a small part of the rotation that actually happens between C1 and C0. So we're going to demonstrate this now. Everybody sit tall, sit well, sit, straight back, straight neck, arms down. Yes, sit, good, okay. So I'd like you to just warm up your neck, rotate your head a few times like this. Just make it warm, get rid of any kind of crunchy, anything inside your neck, okay? All right, and now come back to center. Keep your eyes level to the horizon, okay? And I'd like you to rotate your head all the way to the end, over your shoulder if you can. And then go to the other side. And do this a few times. And I'd like you to notice what happens to the level of your eyes when you go to the very end of the motion. What happens to your eyes? Cants, right? Because your entire face is canting. When you get at the very end, that is the rotation, the very minute rotation that happens between your C1 and your C0, that very end, okay? Sometimes you can have a subluxation of C1. Many people do have subluxation of C1, meaning that the C1 is rotated because of malpositioning, okay? And that rotation gives you a cant. It creates a little cant in your entire face, okay? So just something to think about now. Okay, I'm gonna give you something else to think about. Now, again with your neck, sit up well, sit up tall like this, okay? Do some flexion and extension. Just warming up your neck in the forward and back, okay? the whole neck flexion and extension, okay? And then now bring your eyes level to the horizon. And I'd like you to keep your lower neck stable. Don't move your lower neck. I only want you to think about moving your head, okay? So tip your nose upwards, and then tip your nose downwards, okay? Just warm up that area, okay? Which is your C0, C1 joint, okay? Now I'd like you to bring your teeth together lightly. Just touch your teeth lightly, okay? And then do the same thing. Tip your nose up without moving your lower spine, and tip your nose down. Just flexion and extension of your atlanto-occipital joint. And I want you to notice what's happening to your teeth, okay? What's happening to your teeth, the contacts in your teeth. They're shifting, right? Okay, so when you tip your head up, your mandible goes back, class 2, more retrognathic. When you tip your head down, your mandible goes forward. Correct? Yes? Is that how you felt? Okay, now I want you to think about your patients who can't breathe properly because their airways are so small and they have to move their head forward. And when you move your head forward, you can't keep your eyes down. You have to tilt your head up to see. These patients who have their head forward like this and their head tilted up, they are in capital extension. They are already in a class 2 that is created because of their posture, not because they are class 2. Okay. Something to think about. The next time you look at your patients, think about their cervical spine, think about their position, their posture. If they're like this, if their head is forward, then you know that their mandible is most likely going to be more retrognathic than if they were more natural. Okay? Just multiple dimensions in thinking that we're not just fixing teeth. We have to think of the whole organism. What's going on with the airway? What's going on with the occlusion? Okay? And what's going on in general with the whole system together? Okay? All these structures, all these little moving parts, they're connected with one another through muscles and fascia, okay, connective tissue, and layers upon layers upon layers of tissue and muscles. If one thing is thrown out, the rest of the body is going to change and adapt in order to flow with that, okay? The cervical spine that should be in natural lordosis, just a very gentle lordosis, is made out of 7 cervical vertebrae. And each one of these is separated by an intervertebral disc. Okay? In this plane, it should be a gentle curve. In this plane, we should be straight, in the coronal plane. Okay? If a patient has to move their head forward like this to breathe, they're going to change the structure here. They're going to change the tension on the cervical vertebra. They're going to change the spacing between the intervertebral discs. And these discs can become herniated. And there can be degenerative changes occurring to the cervical vertebra, okay? And when these degenerative changes occur, they're going to affect these areas right here. So let me explain what this is right here. You see this area right here? This is one cervical vertebra. This is this, okay? You take another one of these vertebrae and you put it on top or underneath, and you put this area, this, and then put all of the ligaments. This is the hole through which your spinal nerves go through, okay? This is where your spinal cord goes, and these are the holes that the spinal nerves go through. Like this. If your patient's head is out of alignment, because they can't breathe, because they had a TMJ problem, whatever it is, these elements are going to be compressed. They're going to be compressed by chronic irritation, chronic biomechanical irritation because of the malalignment. So the same degenerative joint disease that happens here will happen here. And it'll go through an active phase and then a sclerotic repaired phase. And the sclerosis will narrow these spaces and will pinch these nerves. And the nerves then, of course, when they become pinched, there's pain, referred pain in the arms, in the neck, in the upper back, okay? Because all these spinal nerves are going to supply, okay, this is the herniated disc, okay, are going to supply these dermatomes. And this is something that we dentists suffer from a lot. As we get older, because of the way we sit, because of the way that we orient our head, because of the way that we position ourselves, many of us, when we get older, we have pain and tingling and numbness in our fingers, okay? And that is because of a pinching of the nerves, the spinal nerves in your neck, that refer the pain and the numbness to your fingers over here, okay? So each one of these is a dermatome. A dermatome is a patch of skin that is supplied by the spinal nerves, okay? And for example, if you are a dentist and you come to me, my mother, for example, she's a dentist, she's retired now, and she always complains of her thumb spasming, you know, becoming numb and spasming. I told her, Mommy, why don't you look at your neck? Go check your doctor, go check your neck. And yes, so she checked her neck and she does have C5, C6 problem, okay? It's fascinating, isn't it? You think that the problem is in your hands, but in reality it's up here. Okay? And it's because of the habits, because of the function, because of how you used your body throughout your life. Okay? Here are the dermatomes. Okay. So, radiographically on cone beam CT, this is the foramen right here. Okay? It doesn't look like much like a foramen, but this is the two parts of the bone and the soft tissue in between. And this is what happens in end-stage degenerative joint disease. You get an osteophyte, and you get a collapse of that intervertebral space. Okay, those intervertebral foramina, like this. And that pinches the nerve, and that gives you the pain. Okay? Okay, so I'm going to now show you a case. I'm going to put all these concepts together in one case. And hopefully you guys are going to take this home and hopefully you'll be able to see these in your own patients, okay? I'd like you to stand up just for a minute. We have 30 minutes left, or about 25 minutes left. Just stand up and stretch your body until I open up the case. Go ahead, stand up. Stand up and stretch. Stand up and stretch.